Good morning, everyone. I'm John from HTN, and welcome to this webinar today, where we're set to discuss what does good look like for a digital patient journey. So over the course of the webinar, we will ask our panel to share their thoughts on this question and share examples of what good does look like and perhaps what isn't good. So we'll go into that. And we're keen to hear your views on that question as well. So what does good look like to you and what's happening in your organization? So really keen to hear from you in the audience, and feel free to share anything in the chat if you've got any comments or anything that you would like to say. So over the course of the session, we will aim to share some practical learnings and examples from our panel and the projects that they have worked on. We will go into some of the challenges in this area and perhaps how to tackle those challenges, and we'll focus on digital inclusion during the session as well, and we'll consider how to measure progress going forward and how to make incremental improvements. So we've got quite a lot to cover. And keen to hear from you as well. So if you have any questions in the audience, type them into the chat and we'll keep an eye on those as we go. And there's some time towards the end for a planned Q&A. So ask any questions that you like into the chat. Finally, this session will be recorded and there will be a write-up from the HTN team so you can read or watch it back at a later date. So let's kick off with some wider introductions. If I could ask our panel just to briefly provide an introduction in terms of their role, remit and organisation, please. So Amanda, could I start with you, please, for an introduction?
Morning, everyone. My name is Wanda Jackson. I'm the Associate Chief Clinical Information Officer and Digital Inclusion Lead at Leeds Community Healthcare.
Fantastic. Thank you, Amanda. Tom, can I come to you next, please?
Certainly. So, hi, everybody. I'm Tom Baldock. My role is Managing Director at Cinetech, who was recently acquired by Restore Information Management, and we provide outbound communications across the NHS, from both digital all the way through to legacy paper, making sure we provide that full range of services, including accessible information.
Fantastic. Thank you. And Shankar, could I come to you next, please?
Hi, I'm Shankar. I'm a GP by background, and I have a digital transformation lead role for NHS England in the London region, and also have a digital role in West and North London ICB.
Fantastic. Thank you. And Simon?
Yeah, morning everyone. Simon McNair, Head of Business Development for Restore Information Management. I kind of manage a team of about 12 people that help organisations, including the NHS, manage that kind of paper to digital transformation program. And in the context of the NHS, it's kind of helping to move from analog to digital and helping to improve or reduce staff workloads and ensure more time for direct patient care. So looking forward to this session. Thank you.
Fantastic. Thank you all. So let's kick off with the title of the webinar. What does good look like for a digital patient journey? And keen to hear your thoughts, perspectives and views on that. So Shankar, keen to start with you, please, with that question. What's your thoughts?
I guess the first thought is, to me, what good looks like is that you don't even have to almost mention the word digital. It should be seamless. Like digital is almost business as usual to a lot of us. And we can talk about digital exclusion in a moment. But if you're having to promote it as digital, without thinking that actually, if you strip away the digital, does it work in a for the patient about what they're seeking? Is it intuitive, easy to understand, and flow sensibly? And I'd also say about what was a starting point and interface. Like often you're stepping off a digital journey, there could be step offs, and it'd be very frustrating if you have a very smooth digital journey, but that final step where you have a non-digital experience can let the whole journey down. So I do think it's really important to analyze that whole journey, not just focus on the digital bits.
Excellent. Thank you, Shankar. Tom Baldock, keen to hear from you.
Yeah, I guess, I mean, to echo a lot of what Shankar said, I think that the key is it needs to feel seamless in that process. I don't think anybody wants to, and if you take it from our perspective, we're looking at it from the very start of the process through sending a communication to somebody to get them to potentially attend something, or later down the line, potentially get their results come through. I think if any part of that doesn't fit what a digital journey in that process, then it can feel really stilted and broken, and not that like it's too many different things bolted together in that process. So I think that's probably one of the things to avoid, as Shankar's highlighted. But I think also we've got to be really careful that sometimes you can go too far with the digital piece in terms of if somebody doesn't want that digital piece. So I think having the systems at the NHS trusts fully digital makes obvious sense to help clinical staff and people like that get to being as automated and as efficient as they can. But if the citizens or patients in this instance aren't able to or don't want to interact in that way, I think we need to be very careful that actually the step-offs again still seem seamless in that process. So because somebody may want a letter or they may need Braille as a great example potentially, and it's very difficult to get digital Braille. So it's making sure that even those step-offs feel seamless in terms of that process as well. I think we've got to make sure that linking them together is really important as well, so that digital works with everything else in the NHS.
Absolutely. Thank you, Tom. Amanda, keen to hear from you, please.
Yeah, I think just to echo kind of what Simon and Tom have said, it's about a good digital patient journey, I guess, feels simple, doesn't it? The patients don't have to repeat themselves, they know what's happening, but actually it also works for staff as well, so it kind of reduces duplication and admin. But just to kind of pick up on that digital inclusion element, it matters because if it isn't easy and it isn't inclusive, patients and service users aren't going to use it. So we need to be asking our patients, our service users, how they interact with digital, so that we can support them with their digital journey whilst respecting kind of their informed choice as well. You know, there are lots of reasons why people don't interact with digital health, and some of that is around fear and kind of literacy skills and ability skills, and some of that is that actually people have the skills and the capability to interact with digital, but they also choose not to. And like Tom was saying, it's really important that we recognise that as well.
Good points. How do we make it easy, do you think? Or no, how do we know if it is easy? Amanda, sorry, can I stay with you?
No, it's okay. I think we can tell by how patients interact with digital, can't we? So if we are asking them questions about how they interact with digital, and we also support them with that. So we're doing a really good piece of work at Leeds Community Healthcare around, we have a screening tool on digital literacy and ability embedded in our EPR. So we have System 1. So every patient we come into contact with, so whether a patient or service user, we ask them about how they interact with digital on a really simplistic level. So can they access the internet? So we're asking questions there around connectivity and, you know, do they have a device? But actually, can they do things that we may think are quite simple, like click on a link? We're all really good. I'm a nurse by background. We're all really good at sending text messages. I'm sure we've all received lots of text messages from kind of GP practices and NHS organisations. But actually, we're asked if we can click on that link. So it's about kind of that user-centered design and having conversations, isn't it, with the people, with our patients and our service users.
Great points. Thank you, Amanda.
I think I just quickly wanted to highlight on I think it's really important actually that potentially we need to consider taking that one step further in this process as well. And in the communication pieces, I think there's an opportunity for the NHS to ask people how they want to be communicated with. And at the moment, we tend to try digital until effectively we don't get the result we want to, and then we try something else. Whereas actually potentially the way to provide this is let's be proactive and ask the question and provide a service that means that choice is applied in that process to make sure that people do feel like they're getting that digital option and get the communication in the format they need. I think that's probably that sort of extra step on from where Amanda's talking is, if we do it all reactively, potentially we've already missed a bit of the boat. Whereas actually, if we ask up front, potentially we can really drive the digital journey for patients going forwards.
Absolutely. Tom Stocker, welcome to the webinar. Do you want to just do a quick introduction for me, just so the audience can get to know you, your role, remit, organisation, please?
That's great. At the moment, I'm supporting Norfolk and Norwich with their EPR programme and integrations, and I had a pressing need to sort something out with order communications this morning, so sorry for being late. My background is supporting various NHS trusts of different shapes and sizes around the country to set digital strategies and achieve them. And increasingly, my work is focusing on, you know, really getting into this world of data and AI. as the future once our software stacks are kind of consolidated a bit more, and I often support with EPRs. So that's me, and yeah, I'll keep picking up on this conversation.
Thank you, Tom. Great to have you join us this morning. Simon, can I come to you? Did you want to lead on from what Tom had just said?
Yeah, I mean, it was I wrote something down earlier, which has kind of, I think, been touched on both in Amanda's points and Tom's. Originally I had, what is the good journey like? Seamless, it's accessible, and it's centered around that patient need. And I think it's the need piece that's key here in the context of personalization. So in our day-to-day lives, we communicate with businesses all the time, and you have a preference in terms of how you want to be communicated, and that is different depending on me. Say from Tom, I might want to receive something in a printed format, I might want to get a text on something out, and it's about personalization, both in terms of how you're communicated with and the content of that message that drives the right outcomes, the patients to be in the right place at the right time with the right information. And also that goes with the clinical and the administrative staff as well. How do you access back to Tom's point about data? How are you getting the information available in the right format, personalized, particularly in terms of that patient journey? So, and particularly as you go through a patient journey, you're going in and out of a number of different healthcare care providers who use different systems. So the fragmentation of those systems will come onto challenges later, but how do you make that seamless when you've got that context and backdrop of different systems and different organizations as part of a individual patient journey?
Good points. Thank you, Simon. Shankar.
Yeah, I mean, Amanda sounds like she's doing some great stuff locally, and I think this point, I think it is worth exploring again, which is there is no consistency across the NHS with any of this. And when you try to push the issue, like, for example, when you try to raise, like, can we get Snowmaker codes to track some of this digital inclusion? It's like, oh, no, it doesn't need to be coded. It needs to say, decline that request. Just record it in your local EHR in terms of communication preferences, but then your local EHR doesn't really track all of this. And then from the patient's perspective, they see it as all one NHS, don't they? So every little organisation. So you almost my wish would be that communication preferences and tracking some of that digital exclusion bits, for example, the smartphone or non-smartphone user, ideally it would be part of the PDS to me, in my mind. And then there's a default sys setting. And then, yes, maybe as individual organizations, you decide if you override it or the patient preferences. And maybe that replicates what we experience in all our lives in retail, other industries, where we can express sort of preferences from the beginning, and it sort of tracks our experience.
Great points. Thank you, Shankar. Amanda, would you like to come in?
Yeah, just on your point, Shankar, about coding. So we the template we have sits within our About Me template. So that's all our accessibility template that's quite new for us, that asks people about their communication needs, kind of what languages do they speak, all those sorts of really important conversations. But we do have it coded. So we have it coded into the records if they're able to perform information technology activities, or if they're unable to perform information technology activities. So the codes are out there, so more than happy to share with anyone on the call kind of our work around the screening tool. But yeah, just wanted to bring that in on that point.
Fantastic. Thank you, Amanda. And Tom Stocker, keen to hear from you, what and your work in terms of patient communications and that digital patient journey. What are some of the things that have worked well in the projects that you've worked on?
I think I mainly work with acute providers, so it might be a bit different, Amanda, from your world. But I think what people have done in the last 10 years is they have usually bought something like Cisco HCC or Cinetech or Patient Portal and plugged them together so that you've got an appointment reminder SMS, you've got initial invitation coming digitally, and often also clinical letters coming digitally to you. And then if you're not accessing them in the next 24 hours or 48 hours, you'll have a failover to a letter engine and you'll have a letter come out to you. And that's kind of where it stops. And pretty much everyone has done that as standard, I think, because there's been NHS England money and policy for it. But that's not necessarily what I have heard patients asking for. And I've been quite shocked by how little patient engagement there is in digital across the trusts that I work in. When I compare that to my old job commissioning services as a commissioner, where we wouldn't even do a procurement without a patient or carer in the room with us, you know. And there are lots of organizations that digital staff can involve in their projects, like TLAP, Sky, the Patient Association, or specific charities probably work with you for free, like the Lung Foundation or whatever, if you're doing something on respiratory. So I think there's huge scope for more patient engagement to really understand what matters to them. And often it will be, do you know what, we need this extra pill on the internet site, or the signage outside your A&E is just terrible, or, you know, it's not even digital, but it's still the same concept of how do we make it easy to achieve what I just heard someone say, you know, like seamless and accessible. Just the basic courtesy of thinking for 10 minutes and then putting into place the information that someone new to the NHS needs to access their care. It doesn't take that long, but we can do it usually across all our systems, and also our skill set around user research and engagement. If we activate that skill set in digital, it can be really helpful for just general patient accessibility across a trust. So that's my perspective from acutes. My big interest area is AI and data, and combining that. So of course, every patient will say, I don't want to have 5 different patient portals for each provider, I want one. Yeah, and that's the ICS's job to coordinate that and to achieve a better experience where people have complex care journeys. That's fine. Pretty sure that will happen eventually with the NHS app, etc. But the area that I'm really keen on, when I go and speak to patients, they go, yeah, digital, fine, whatever. But do you know what really matters to me is the fact that no one listened to me when my cancer came back, and that was missed for 6 months. The fact that I have got to go to all these, you know, like rheumatology appointments, and I could do that from home, and that means I could keep my job more easily and look after my kids. For me, it's the more fundamental drivers of what makes a patient experience of getting care in the NHS much better, what improves their outcome. And we've got this really low hanging fruit in digital because we know how data is collected. We know about care journeys. We often in the same team as the BI team. And we can ask questions and bring value in a completely different perspective to our operational colleagues or our clinical colleagues, and start to make sort of connections to enable our whole organizations to do better for a particular pathway or a particular scenario. And for me, that's what good looks like for a digital patient journey. It's not digital as a way of enabling an existing pathway. It's digital as a genuine pathway partner.
Mm-hmm.
How do we collect bloods totally differently? Because we can. How do we, you know, like, how do we do the arrival and attending process and the outcome process in outpatients differently? Because we can. How do we do community mental health differently? Because we can. We've got this whole new sweet shop of technology and AI capability and data science, and yet we're still very limited in how ambitious we're being for our patients.
Great points. Thank you, Tom. Shankar, would you like to come in?
Yes, I think Tom's right. I mean, we don't do enough UX user experience, and even if we do it as a tick box. It's like a few patients, not representative, or maybe two representative, two digitally savvy, and not representative of the digitally exclusive. And then on the other bit of the user bit, also our staff, you know, as the stakeholders of I'm going to say primary care because I represent primary care a lot. You know, like we could talk about NHS app, but we can have lots of user perspectives of it, and often those staff have to navigate those patients through that digital journey. So, and sometimes I think it comes down to not enough resources being earmarked for that process. And then even if you do get lots of user feedback, you don't have the capacity to implement it, or it gets part. So then it causes user frustration that you've raised it, you keep raising it, and you don't see any progress. And then you get the typical scenarios of, well, no one else has mentioned that, when you think, well, there must be thousands of people that have just fed up of mentioning things. So I do think it's about, you know, you sometimes have that drive before you go live with the product, but you don't keep that drive going once it's live, and it needs to keep improving. So I think it's an important thing to keep as an ongoing process throughout.
Great points. Thank you, Shankar. Tom, Tom Baldock, would you like to come in?
Yes, I mean, I also agree with other Tom in this instance. I think one of the things and I've been obviously part of Cinetech in that situation. One of the things I've tried to drive in the past is let's listen to patients, let's get information from patients, and actually the take up of that is in general is really low, which is really interesting. It's almost like people don't. It's almost like we don't tend to focus on what's best for the patient. We tend to get a bit distracted by what's cheapest or what's best for the NHS in that situation. And I think ultimately what's best for the NHS should be what's best for the patients in that environment. And I get the fact there's budget constraints and resources and all that sort of stuff. But I think that's partially where commercial businesses can help. And I think that's the key in this environment as well, is like if a commercial business speak to them about what the challenges are and actually let's get that information and then get it to people like Tom who's can use AI and sort of things like that to actually make sensible decisions as to what can happen going forwards. Because I think, and even on Shanker's point, I get the fact that there's sort of a malaise of if you say things multiple times and nothing changes, but that's also down to communication. It's like, look, we're really trying here. We're really listening to what the problems are from your perspective as a patient. Actually, we will get to these, but you need to give us some time because it's a big thing, the NHS, and actually we've got some constraints along the way. And most people will be accepting of that and hopefully then keep raising those pieces. But ultimately it's about communication to people in a format and getting what they need or want or think would make their life better or their journey better as a digital patient in that environment. And that might just be I don't want to ever see another email or text message from you, but let's actually stop and listen to that. That is an option.
Tom Stocker, would you like to come in?
Do you mind if I be really cheeky and ask a question for Amanda? So, like, because Amanda, you're like in this really interesting position, associate CCIO. So you will have a clinical background and also you'll be involved in the digital team, and you'll know that nearly everyone on this call, nearly everyone in the NHS has a good heart. They're well motivated. They're really smart. They're often moaning about the things they wish would happen, but don't happen. We all want this for patients, but there's something about how it gets stuck at the governance or leadership or practicality layer. And I've seen that get unblocked by exception with real strategy, a really good strategy, really good leadership around the strategy. But I wonder if you could help us get some insight on what would it really take to shift a NHS organisation into a more patient-centric, energetic mental model with a digital programme.
Yeah, thanks, Tom. Yeah, so I'm a specialist public health nurse by background, so adult nurse and health visitor in old terminology by background. Yeah, you're right. I mean, most organisations have CCIOs like me or chief nurse and information officers, so they do have clinical leadership in digital teams, don't they? But it is about what I've found works particularly well, certainly for leader community, is going out and having conversations. We can't expect our staff on the ground to come to digital teams and have conversations with us. You've got to spend time going out and having conversations with them. And for some, it doesn't come easy, does it? You know, how do we interact? I'm not going to understand what a clinician is talking about. And it's the same for patients as well. We need to go out to them to have conversations. You know, we can't expect our patients to pitch up at our head offices and have conversations with our digital teams. We need to go out into our local communities. We've got a really good community kind of third sector organisation group within Leeds that work really well. We have 100% digital Leeds who are run by our Leeds City Council that bring together all our partners that are interested in digital. So I often, I'm part of their group and I go out and have conversations with our patients and our service users. It's not difficult. I don't know if it's the nurse in me. Be curious. It's as simple as be curious, ask questions, but you do have to reach out to people. And you're right, the projects that I've seen really be successful are the ones that have involved clinicians on the ground, not just your leaders, but actually patients. I think we're absolutely right, user-centered design. absolutely needs to include patients, but it also needs to include staff, because they know what our patients want as well, don't they? So I think for me, that's definitely what good looks like in practice. And don't get me wrong, all organisations do parts of this really, really well, and so do we. And we definitely have learning to do from different areas. But I think as a simplistic, my take-home message is be curious, talk to people outside of the digital world, and help them understand what the aim is, and help them drive the aim with you.
Fantastic. Thank you, Amanda. Shankar, would you like to come in?
And just picking up that be curious thing, so totally echo that. What also really stuns me is how many times I've seen things rolled out where the people rolling it out haven't actually tested or tried it themselves. Okay, just something that jumps to mind, being like, okay, like, I'm not saying I've watched a lot of Gordon Ramsay stuff, but he'd scream at that chef sending stuff out of the kitchen, not tasting it. If you ever watch any of his kitchen nightmares, why do we do the same with digital stuff for our patients? I sometimes feel like when I'm deploying something, I sometimes feel, am I the only person who's tested it and found 6,000 different bugs? So I do think, like what we said, like we've got to experience what the patients experience it, whether it's directly testing it, whether sometimes maybe that light bulb moment only happens when some person actually is a patient themselves in the NHS or trying something, they realize, oh my gosh, this is awful, and I'm responsible for this. Or maybe close experience of family, patient, friends. We may see posts, reviews, ratings, anything like that. And I do think that's one thing I would really emphasize, is that we do need a feedback loop, whether it's users raising issues with the digital journey, whether there's transparency. What I think is it's when to pick up the point about frustration, when you feel that there's no progress with what you're feeding back. Really, we need like roadmaps of digital products, that things that clearly show what has been fed back, what has been considered, what has been discounted, so people feel that they can feed back and can shape the future of that digital journey.
Fantastic. Thank you, Shankar. If there's somebody on the call who's responsible for communications, what would they do, or what could they do other than like user feedback to improve those communications? Is there anywhere that they could go and look for guidance and advice, and or what would be some of those best practices in terms of the communication piece? Amanda, have you looked at that at Leeds Community in terms of the content itself, in terms of what is being sent and how that can be optimized or improved?
So yeah, we all our digital project managers, so all everyone that kind of heads up digital project, we've got I devised, I don't want to say simplistic, but it really is a kind of user design strategy around involving people right from the start. So I think that helps, doesn't it? That kind of the comms around on a simplistic level, and I keep saying simplistic level, but I truly believe it is. It's just about having conversations with people and bringing them along with your journey, but they have to be involved right from the start. So right from the kind of the project initiation and the idea of a digital project. Otherwise, we are going to be rolling out digital tools, digital solutions, or talking about things like the NHS app that people just aren't going to use because they don't know about it. They don't know the benefits. They don't know how it works. They don't know how to make it work. They're scared of it. So I think it's that, it really is that simple of bring people along from the start. It doesn't have to be a wide communication strategy. It doesn't have to be anything complicated. It's just getting people involved from the start, which is the essence of user-centered design, isn't it? It's just a fancy way of saying it.
Tom Ball.
I was going to say, I think there's an interesting point here, and I think I agree with everything Amanda said. I think the user-centered side of things is obviously the best approach to go. But I think one of the things we probably need to stop thinking of communication as is a commodity. I think that's historically what it's been considered as, is it's the cheapest possible way you can get something to somebody, whereas actually, I think in today's world, with the myriad of different communication methods we've got, it is starting to become an expert industry. It's starting to become something where actually you need to understand exactly what the positives and negatives of every format is. So, like, to add a geeky piece, is to send an SMS, you get 164 characters before it becomes 2 SMSs. It therefore is long amounts of information a sensible thing to send in an SMS? Clearly not. Is email particularly, there's evidence to show that emails are not as easy to read on screen as a physical printed piece of paper. So there's so much complexity, and I've picked a few of the really simple ones in this environment, but you can dig into all sorts of different pieces. And actually, I think that's where potentially the NHS needs to fall back on actually there being expert communications providers across the country. Not just in there's other people who do this as well. And then you've got even people like Royal Mail have got a specific team for making sure communication is in a format that makes the best delivery for when it lands to somebody. And there are people who provide that service. So I think that's the piece that probably needs to change in specific to communication, John, from your point, is actually it needs to stop being seen as a commodity and seen as an expert industry that actually go out and listen to the advice. And like, it sounds a bit silly, but from my point of view, if you looked at a letter that's written normally compared to somebody who's got an accessible need for an easy read, you get to the point of going, why is easy read not better and clearer for everybody? Like, and there are reasons and bits where it can annoy people and pieces like that, but arguably it's simpler and easier to read. And is that not what communication's designed for? Do you not want it to be as simple and easy to interact with as possible? So I think that's where those questions need to be discussed at sort of an expert level to get the best out of communication and drive that digital piece going forwards. And the NHS app is a huge part of this. It's got the opportunity to really drive digital forwards if and when it's done well in that environment.
Thanks, Tom. Amanda.
Just wanted to pick up on what Tom was saying about kind of the accessibility. If we write everything with the average reading age of between 9 and 11-year-old, we've hit the mark, haven't we? That's what we should be doing. You know, everything should be easy read, meet the national, the average reading age, and then we're not overcomplicating things. I'm sure we've all received letters, or be part of communications from health that we even those of us that work within health go, oh, hang on a minute, what does that mean? But we should all meet the same standards, shouldn't we? We've been doing a piece of work around we've brought out a new website, our information hub, and our services have been writing their service information absolutely as they should. But what we've said to them is it needs to meet the average reading age of between 9 and 11-year-old, and we should all stick to that. I think as a minimum, it should be easy to read and easy to follow.
Absolutely, thank you, Amanda. Shankar.
Yeah, so first of all, like communication in terms of training, echo the points made, but also the flip side is obviously that surely it needs to be so intuitive, simple to use that you don't need that much communication. Isn't it a warning sign that how many pages or how many slides you need to explain something is inversely proportional to how easy or intuitive it is? And we can get so used to that, but we need to think of the normality, people shopping online and things are not getting training. Why is it that different in the healthcare system? So I think that's one thing for us to think about. And I just want to pick up another question in the chat about from the audience about EHRs and stuff. I want to talk about maybe a digital journey which isn't quite about communication. So the example would be electronic prescription service, EPS. So here in primary care, obviously we got it really early, we're benefiting. It's difficult to really push that through all the different EHRs to maximise it. And then from obviously Amanda from community, I know that obviously you've now got EPS in your system one, but effectively, that's not all community providers have it, and a lot of our hospitals are really struggling with the standalone platforms or just waiting for their EHRs to engage. So I think it's the next problem about digital journeys is that the patient's frustrated why different parts of the NHS can't get the same experiences, and they won't understand the complexity of EHRs. And it comes down to how do we contract. So when we start that journey, when we're planning that strategy, how do we really start to lock down the future quickly and plan ahead so it becomes uniform? And when we look at it, that's to me sometimes the example where you don't quite see the patient side of it. Like the patient side of it is that in a wonderful way, they don't need to understand a lot of the EPS stuff in the background. They just need to know, oh, I don't have to run to get a piece of paper. It just goes to my pharmacy. And then we talk about communication. Some of the other challenges about now rolling out prescription tracking on the NHS app means that, if all the pharmacy systems are also integrated with that, the patient gets notification when their prescriptions are ready. So you look at that seamless journey of how do we get the HRs all on board with that vision, that strategy, and contractual, where it's not, you ideally want it not just to be contractual, that they also buy into the patient journey. They would want to do it, seeing that it adds value to their products.
Great points. Thank you, Shankar. Tom Stocker, keen to hear your perspective from a trust side and the EPR suppliers you've worked with, and leading on from Michelle's question in terms of it's difficult to personalize comms for patients. Is that something that you have seen? Is there a way to tackle that challenge?
Yeah, definitely seen it. Like even just like there's something stupid like the a lot of the GP addresses in the spine have all caps, and then the secretaries have to rewrite all caps to not all caps because it looks like it's shouting to the patient, kind of thing. So like even small things like that, like EPRs could fix that if they were bothered, but they don't. So NHS Digital people in NHS England, they could fix that if they bothered, but they don't. So there's lots and lots of small things. I think the strictures we give ourselves around the concept of a letter are fundamentally unhelpful. Letters are quite an antiquated concept. I mean, even forcing clinicians to write letters to each other seems inferior to coded data about here are the prescriptions, here are the actions, or whatever. And I but there's nothing, as long as you have a good relationship with your EPR, there's nothing stopping you innovating, and there's nothing stopping you structure your patient communications how you want to. It's just made hard and expensive. So there might be specific things that a colleague online has, Michelle has in mind, and maybe she can share, and then we can comment more. In terms of there's this other question about what framework do we use to measure patient-centered outcomes following digital tech implementations. In reality, it depends on what you're doing, right? Is the short answer. So like Surgery Hero is an app I've worked with before that was designed purely to mobilize people before surgery, and maybe use physio instead of surgery, and then improve their outcomes after surgery. So that's all MSK, and you'd be looking at, well, what's your EQ5D, what's your functional mobilization, what's your post-surgical recovery, and that's what you care about. So I think you've really got to think through what are you doing with each tech implementation, why are you doing it, and then what matters. But coming back to your question, John, there's no restriction on how you collect information from patients now. It's very easy to set up surveys. It's very easy to send targeted surveys to random samples. It's very easy to analyze it now, a lot easier than it was even a year ago. Then you've got workshops as well, and direct engagement, and Amanda's point of going and speaking to people. I think it's harder to go to speak to patients, but you can bring them to you. And trusts often have patient groups. I try to avoid them. I go and speak to them, but I find that those patient groups, they know too much. They're like us, like they've become indoctrinated into the ways of the NHS. I think the most productive conversations I have with patients are walking around inpatient or outpatient areas where you catch people that would not turn up to a workshop, that are less confident, and that you can have a quick conversation with. And even better, go to your data, find the people with the gnarliest patient journeys in your trust, and bring them together around a specific, like objective. People will turn up to one workshop if you pay for their bus ticket, even if they're not going to become, standard patient representatives for the next 10 years. So I'd recommend those routes. I don't think it takes that much extra time to do it.
Great points. Thank you, Tom. Simon McNair, keen to hear your thoughts on the conversation so far, but also we've spoken a lot about improving the digital journey here, which is fantastic. How can we measure progress in the next year or so? And where do you think we can get to in the next year?
Yeah, there's a couple of bits for me. I mean, we've talked a lot about communication and digital deployment, systems fragmentation across the healthcare system. I think one of the, given the work that I've done, the teams have done at Restore over a period of time, I think it's about the patient record and information and data. It's about getting that in the format that it needs to be to support clinicians, to support the administrative teams, but also to empower patients. There's obviously a big program of making sure that that information is available and accessible to all in a format that can be used. A lot of those are default digital applications. We've talked about the NHS app. Some of the work that Restore's involved in is around moving from paper to analog and making sure that information and data is in a format that can be accessible and used, whether that's through clinical EDRMS systems into EPR, or whether that's particularly Shankar at a GP level, making sure the legacy of the Lloyd George records and the patient records are in a format and accessible on the National Document Repository. That's all making that accessible to both clinicians and patients, which ultimately improves information available about a patient journey and a care pathway. So I think that's one area. I think ultimately it's about customer surveys and experience that patients have, and being able to monitor that more effectively and more frequently as part of a patient journey. I think it's clearly around driving more efficiency and in some cases automation, so that you're freeing up time for admin and clinicians to be able to see more patients. So how do you reduce some of that administrative burden across the NHS so there's more time for frontline and patient care? Some of the measurements around did not attend rates, I know that this will be something Tom and the team have focused on extensively. It's about minimizing wastage so that the system is more efficient. So we've got clear communication going out. People are attending at the times they do. The information's available to be able to make effective decisions around patient pathways and patient journeys and outcomes. So I think it's a combination of some of the existing measures, but also 100% agree bringing the patient back into that in terms of that feedback loop and surveys and understanding what's working, what's not, and having a clear plan to change a course or a direction if the feedback says it's not working for patients.
Fantastic. Thank you, Simon. Shankar, can I come to you? Keen to hear along the lines of what isn't working. So we've spoken a bit about what is and how it can, but is there something that you see in practice that patients are saying to you?
Okay. Thinking of primary care, one that we've discussed recently, I'm going to be discussing it more, I'm going to go with the one we've kind of covered already, appointment booking in primary care. It's an example where primary care say where it doesn't really match the design of what we're actually doing now. So a lot of practice is on a total triage process where you're triaging on the request. It goes against their model to then allow some patients to book directly. But then the second bit is often we blame the NHS app. We think, oh, it's a frustrating experience, can't find GP appointments. So, and oh no, why is my practice not releasing those appointments? But actually, we've got to do the actual design and review of the actual process, which is often the EHR, the appointment systems, will never design for a patient to self-book or self-manage. And they're not intuitive. They're not explaining what appointment can be used for what purpose. And sometimes we need to accept we need to do a radical redesign of the system, the processes that then renders the NHS app. So, for example, a patient may need to search for a cervical screen appointment, not for an appointment date and time. I mean, would you book your film based on an appointment time? Would you choose the film you want to watch in the cinema and then look for the date and time? That kind of design, it seems really obvious. But unless we do some of those obvious things, we'll get a lot of frustration where that patient books to see me and I'll be saying, oh no, do you know what? I have absolutely useless at dressing your wound. and that nurse who I can't get you into an appointment because she's now finished for the day would have been the right appointment. So how do we change those user journeys? And when we talk about appointments, even like that hospital example we just said, I mean, we may be able to now manage our appointment, maybe able to even maybe change our appointments. But what about that last minute frantic? You're just about to approach your appointment. You can't find that hospital car parking space. You're running late. Everything's going wrong. There's no functionality to get that message to that thing to know, is there hope? Can I tell them I'm running late? If you're lucky, you'll be told to maybe phone a phone line at the hospital, which no one will answer. So you've really got to do that end-to-end journey mapping. And I think we've just got to accept that nothing is perfect. Even in the non-digital patient journeys, nothing is perfect. If we think something's perfect, then we've got it wrong. So how do we keep iterating, accepting that everything has to constantly improve, tracking that feedback, those outcomes, and moving that goalpost further and further ahead about what we would want as patients ourselves?
Great points. Thank you, Shanker. Amanda, is there anything that you would like to add to that from what you're doing at Leeds Community before we move on?
I think it's assuming that digital first isn't always the best thing or the right thing. You know, there's something around understanding kind of our digital pathways and workflow, and understanding where kind of the struggle points or the pinch points, and not just putting a digital process into a pathway that isn't already working. Does that make sense? It's kind of understanding it from that side of things, and you know, to kind of make sure that we design with, I think it's back to that, and kind of around patient choice, and understand kind of the uptake and kind of what the need and the desire is. I guess back to that being curious, but also finding and bringing our staff along with the journey, but finding and understanding what the hook for people to get involved with and use those digital processes are.
Great points. Thank you, Amanda. Could we talk about automation and AI and how that could perhaps be utilized in this space? Are there any opportunities, challenges, risks? Tom Baldock, keen to hear your views on the introduction and potential of AI for this.
Yeah, look, I think you used automation and AI as almost like they're one and the same thing these days. I think we need to separate them. Is probably the first part. Is you can automate something without AI being involved, and you can automate something with AI being involved. So I think it's different things, and automation needs to be carefully done so that it removes mundane tasks and gets people so they've got more time to do what's important, and that's looking after patients and getting the right health outcome for somebody. AI, I think, is a tool that has an exceptional amount of benefit in a huge number of areas, but also needs caution applied to how it's operated. So Tom highlighted it earlier, was that you can AI and its ability to read data and provide information out, and the getting feedback from patients and using AI to get that and summarize it and give you a real view of what it is an incredibly powerful tool for that sort of stuff. But let's be honest, a great question in this environment is who wants an AI bot to be the first thing that you run into when you're trying to book an appointment? Is that it? Like, some people, it will be their preference. Let's be clear, that will. But normally, if somebody says, "Oh, I'm trying to book something through an AI bot," you can almost hear the frustration in their voice at the fact that they've hit it at that point. And there are some use cases where it's the right thing, but we need to be careful in the NHS that we don't follow the route of your electricity provider, who obviously have no interest in actually talking to you. I think we need to be really cautious the NHS don't go that route. We need to make it easy and people want to communicate. So automation and AI is, I think, 100% the right thing, and we need to be encouraging its use across the NHS and in general. To be honest, it's one of those things, but we need to make sure that we're using it for the right things, not everything. And I think that there's a risk of, because AI is the bright shiny thing, everybody wants to use it for everything, and I don't think it's necessarily the case that it is the right thing for everything, but it definitely is the right thing to use for a lot of things.
Thanks, Tom. Shanker, would you like to come in?
Well, I think we are using in primary care AI at the front end, like that first step, whether it's on websites as AI navigators, receptionists, or now in London we're starting to do that online consultation and AI assistance in that first step off from NHS app when someone's seeking help. But if I put that aside, where I would like to see it maybe is to assist patients when they're going through their health records, because obviously their health records are really dense, really complex, not even easy for us clinicians to understand each other, and how we can use AI in a safe way that the patients can understand their records. Like, for example, maybe even a question and answer type things, not even just looking at summaries, but because summaries have got obviously their advantages and potential risks. But it could be like, if I give an example of one that I've had where a patient would ask me, oh, could we test for diabetes? I'm wondering if if we've done that. And I had to explain to them, well, actually, you didn't realize, but we did an HbA1c test a couple of months ago that actually is a screen test for diabetes. That was fine. It's a similar parallel where, could they use AI bots to interrogate their records if they're looking for things or asking questions about what does this mean, with massive caveats that obviously there could be real implications, disclaimers, accuracy, stuff like that. I think that could be a useful step.
Great points. Thank you, Shankar. Simon.
Yeah, just something struck me as we were kind of talking about this, I think, and it's partly Tom's point around those areas where you're happy to not interact with a human versus where you absolutely want to interact with a human, particularly in a healthcare setting where it's personal. It's about your healthcare journey. It's about, ordering something online is very different from getting checked out related to kind of a condition you've got or something you don't understand. You're going to want to have that combination, I think, of effective use of technology, but that personalization and a healthcare professional you're going to want to speak to and access. So for me, the kind of automation AI data piece is much more around at a healthcare system level, freeing up time for healthcare professionals to spend more time, because it's a personal journey. It's not ordering an item online, it's not e-commerce, it's about your own personal healthcare journey, and people want that time with specialists because they're not experts in their own, in the conditions, in what the best route is. So you're going to want to free up, use the systems, the technology, particularly AI, to free up time for the healthcare professionals to be spending the time with patients in the way that they need. But I 100% agree with Shankar that the pace with which technology has moved in the last 6 months versus the last 2 or 3 years, it's getting to an inflection point where we're seeing pilots moving from AI pilots into operational AI at scale. And therefore, I think you're going to see massive benefits on that. And if the benefit is freeing up time for healthcare professionals to spend more time with patients, that's what patients want. That's also what obviously the healthcare professionals are there to do. It's not about back office administration. It's not about things that systems can and AI can do more effectively for admin and clinicians and patients, but it is certainly about freeing up time for a more personal human interaction with healthcare professionals as a result.
Thanks, Simon. Tom Stocker, keen to hear your thoughts or what needs to be considered in terms of AI in that digital patient journey.
We are in a global dark spot for AI in health because Europe has these things called the medical device regulations, and they're being very strict with them. Everywhere else in the world is going hell for leather on this. If you go to an American provider, AI is used by the patient before they get there. AI is used by the clinician to help with treatment and diagnostic decisions. AI is used to help draft radiology reports, just the standard off-the-shelf stuff. In America, they've got data centers segregated to each state to comply with HIPAA laws. We don't even have data centers. We don't have enough data center capacity. Almost every AI that a startup is using or whatever is not compliant with keeping our data UK sovereign. It's going to Belgium or it's going to Ireland. And often, all clinicians I know are using AI without telling anyone. They've ended up putting loads of patient details in there, and they're going straight to Sam Altman and people to use that patient data for marketing. That's happening more among junior doctors, but I have seen, and I've been engaging with consultants who've been doing this, and the reason is because they feel they can deliver better care. They feel they can communicate better to patients. They especially where there might be foreign language doctors. So there's this huge area of benefit, and we are we are cutting our nose to spite our face. We are forcing the system to use this stuff illegally. There is potentially a fix for that, which I'm trying to create among a network of forward-thinking trusts that want to push the envelope a little bit, want to think a little bit ahead of the center. And we're developing some great things. Some of them are chatbots, Tom. so one of the things that we've developed is what we call Symbot at Clatterbridge, and we've got this to prototype level, and the breast oncologists are really keen. Pfizer's helped us to fund it, and basically the premise is, look, you've got breast or lung cancer or whatever. We need to know about your symptoms and certain symptoms in this very structured way that we call CTCAE grading. And there's a real difference in how we treat you and how we give you supportive medications to stay on treatment if you are a grade 3 or a grade 2 for your bowel habit, for example. Now, we don't have enough nurses. No one in the NHS has enough nurses to ask every day. And lots of our patients are happy with the survey. That's great. And these surveys and these chatbots, there is peer-reviewed RCT evidence. It saves lives because we catch it earlier. We support people to stay on treatment. We reduce their tumours. It's very, very simple. So for that use case, patients have asked us, please, can I just have a chatbot? Yeah, I just want someone to phone me. I don't want to fiddle around with an app. I just want a chatbot. So we've trained that chatbot, and the first prototype was absolutely rubbish and a bit like a terrible call center. But it's been incredibly quick working with an independent supplier to get to a chatbot people are quite happy with. And I think that's only going to get easier and easier in the future. So I think all these tools are really, really interesting. I think it will be the focus of digital teams over the next 10 years. And the NHS has currently got their head in the sand. Not all of the NHS. Primary care hasn't, because they've got the pressure to make use of this stuff. But I think that this is going to be a lot of what makes our jobs up in the next 10 years.
Thanks, Tom. Amanda, would you like to come in?
Yeah, just a very quick point on I agree with you, Tom, AI chatbots, and when we just go back to the earlier conversation, Simon, you were saying around releasing staff capacity to kind of hands up to free up kind of hands-on care. When we look at kind of the amount of calls, say, coming into a 0 to 19 service, for instance, you know, from parents, it's all kind of routine, and I say that with the greatest of respect, but routine questions around how do I wean my baby onto solid foods? How do I support my baby to sleep well? Those sorts of things. Those sorts of questions are brilliant for an AI chat, but they're not necessarily questions that a parent wants individualized care. They just want a starting point. So the use of implementing a chatbot to kind of direct to evidence-based sites, for me, I agree with you, Tom, is revolutionary. It frees up a phone call. Those phone calls usually take, looking at some of our data from our 0 to 19 service, 20 minutes, 30 minutes, you know, even 45 minutes to an hour, because you get involved in a conversation where actually as a parent, you want to just come away with a where do I start? So I think Tom, you're right. We're on the brink, hopefully, of a little bit of a revolution. And as long as we've got all those AI governance structures in place, which is something we're working on, I think there's definitely a place for AI and automation kind of moving forward.
Excellent. Thank you, Amanda. Tom Baldock?
Yeah, look, I think, to be fair, I think that the point I was making about AI chatbots was put across badly in that environment, and both Tom and Amanda have highlighted some great use cases for that in that environment. With the piece where I was highlighting is if you're making your first entry into something and you're trying to, I don't know, take a great example. I got nailed by this a few years ago where I'd got a really bad dizzy spell that had been going on for a long period of time, and the first thing you did when I got a phone call was it went to a chatbot, and they were like, "What? How would you describe your symptoms?" And you're sat there going, I'm dizzy, and then they're like, "Is your how?" Like, and you're like, "Well, I don't know." It because I'm not capable of explaining it. The chatbot wouldn't help me in that environment, and it might be that I'm coloured by a bad chatbot in this instance. But the examples you guys are giving, I get that. I get the benefit in that environment, and I think it exactly makes the point I was making: is AI needs to be used in the right environments and for the right thing, not everything. And if you use it well, it is incredibly powerful. I mean, Copilot is a great example of, if you wanted to take the salient notes out of this meeting and publish those to everybody, it'd be a great tool to be used. So it is 100%. There are points to use it, and those are great examples where chatbots are effective in those environments. But again, I think we just need to be cautious. It's not every use case is the right thing for AI, and in reality, it's the same point Tom was making earlier, is we need to ask what people want. It's no different in principle of asking what they want before you deliver it. I think is the key. Is if you just deliver it and they don't want it, it's not going to land well.
Absolutely. And I think it's a webinar in itself to talk about AI in terms of patient comms and those ins and outs of that. We've just turned 11 o'clock, so I'm conscious we're going to have to wrap up the session now, but thank you to the panel for joining us. It's been a great discussion. I think we've covered a lot, and it's been really practical for people in the audience, so I hope everybody in the audience has enjoyed it as well. There will be a write-up published to HTN in the next day or so. Keep an eye out for that. But it's turned 11, so thanks everybody. Thank you to the panel again. It was a fantastic session. I hope you have a nice day, and we'll see you on the next webinar. So thanks everybody. Take care.
Cheers.
Thanks.
Bye.
Thanks, John. Thanks,
Cheers.
everyone.
Bye.
Bye.